You know, one of our passions in the vascular group is coordinating vascular care. It is something that was really done poorly in this country before. They have a trauma network, a thoracic network, but they've never really concentrated on vascular care. And I think what Dr. Shah and my predecessors have done is establish a precedent and a quality of care that is unsurpassed, and we've been able to expand it to a large network. And tonight's meeting is really on how to deal with aortic emergencies, how to deal with vascular emergencies, and we have a tremendous faculty to do that. And the first person I'm going to introduce is Dr. Dennis McKenna, who's was brought up in Albany, he had his medical degree from Albany Medical College after graduating and matriculating from Cornell University. He did his residency in emergency medicine at Albany Medical Center and has now assumed the mantle as Chief Medical Officer. He's been instrumental in forming our international training program, which I think is something that's unique in Albany that's going to be copied throughout the country, of training vascular surgeons from around the world in the newer techniques and the old techniques that we have perfected in Albany. But Dennis has been instrumental in that. He's been helpful. He is truly a guiding force in Albany Medical Center now, and we really appreciate his perseverance and his direction that he's done since he's assumed the job as medical director. Now, looking through his CV, which was very interesting, I also noticed that Dennis was an actor and had a part in a medical play, as it were. And I think I wouldn't say that's his most incredible accomplishment, but it puts him in a new light to me right now. Dr. McDreamy, as some people call him at work, but I didn't want to bring that up. But Dennis is going to really talk to us about triaging vascular emergencies. He's a good friend, not only to us, but to vascular surgery and to vascular care. And it's going to be a great opportunity to invite him up here to speak. Thank you, Dennis.
Thank you, Clem. Let me begin by saying I heard the introduction about people who are regionally, nationally, and internationally known. Well, I'm reasonably certain that my children know I'm a doctor. I don't think I could go much farther than that. Although if you ask them who the best clinician in the family is, they would undoubtedly say correctly, it's my wife who's a nurse. So good on them. Actually, two quick acknowledgments before we start to the vascular group. I'm getting a little feedback here, I apologize. Maybe step back. Who are absolutely top-notch, world-class group. The opportunity to come and speak with you guys is an honor of mine, so thank you very much for that opportunity. And to my ED colleague, Dr. Cadigan, who actually not only filled my head with some of the knowledge which I'm going to share with you today, but actually provided some of the slides about aortas. So let's just jump in and begin. Just a little bit about our emergency department. I consider our emergency department to be the most sophisticated in the region, staffed not only with board-certified emergency physicians, but obviously one of the things that makes our job great is access 24/7 to specialists, including the vascular surgeons. And we are obviously the region's only level 1 trauma center with approximately 700 helicopter flights bringing in critical patients every year. We're central to the operations of the medical center, obviously not only in the stabilization of some of the critically ill patients, but we're responsible for a majority of the admissions and obviously a super majority on the weekend. Now, as many of you know, we serve a primary, a secondary, and a tertiary area. I point this out because many of those patients in the green zone come here for the services of the vascular surgery group, and let's make no doubt about that. They come all the way from the northernmost parts of the state, eastern and western, etc. Our primary area obviously is Albany, Schenectady, Saratoga, and Rensselaer County, which makes up about 2/3 of our patients, but another third of our patients come from areas farther than that, with a total of about 3 million people in our population area. A quick look at the census in our emergency department. You can see it's obviously, like any other emergency department, a growing census of patients with an average daily census of about 200 people a day. Busier days, you may see as many as 250, but the more important number may be the admissions. So anywhere between 60 to 70 admissions a day coming through the emergency department. And obviously some of them are going to be vascular emergencies, and so we'd like to focus a little bit on how we identify those patients. Bird's eye view of our department, just focus on the bottom right-hand corner in green. Obviously, ambulance entrance to the right, and the area in the green is designated to our highest volume, sickest patients, and that's where those vascular patients would go primarily, and that's where some of our specific equipment to treat them rests. This is just a quick mosaic of care, an actual screenshot of what you might see at any moment in the emergency department. And I do this to point out that while we're trying to take care of the vascular emergencies, you're obviously taking care of someone who may have a cardiac arrest, a fracture, a stroke, someone hemorrhaging who's pregnant, and maybe someone with the flu, and any number of patients. And so you need to have lean systems with the best technology and access to the best specialists right away. That's what we're very fortunate to have, and that's what we're here to talk about today. So obviously, I just want to point out very quickly that when we're dealing with some of these patients who may be a trauma patient with a vascular emergency, there are any number of things that you need to do in that first hour to care for that patient. And actually, if we sat down, we might even be able to come up with a longer list than this. But what's very important to us is the collaboration we have with our vascular surgeons, so that if we need them down there, once med flight arrives, which is at 12 o'clock, we put out that page and we create an alias chart. Then the cascade of events occur in that first critical golden hour in the department. And it's very important that we have an integrated team of providers who can care for that patient, whether they need to go to the VIR suite, whether they need to go to the operating room, or just be admitted up to the SICU. So let's talk about the vascular experience. If you took the patient population of 50 years old or older who came into the emergency department last year, that would be about 18,000 patients. If you said, give me a cut of those patients who presented with just chest pain or abdominal pain, you see about 1 in 10 fall into that category. Now, a thinner slice shows that in that group, there's 232 people who have a AAA, there was 55 who had aortic dissection, and there's 89 who had mesenteric ischemia. And I'll say those numbers probably underrepresent the volume that come through the emergency department, because it doesn't include the people who are direct admits, and it doesn't include people who have other secondary or tertiary diagnoses that we haven't captured. But obviously a high volume of very sick patients. So the question is, how do we know who they are, and how do we render treatment to them right away? So I want to focus on 3 areas primarily. We want to talk about AAAs and the enhanced use of ultrasound in our department, a small talk on vascular extremity trauma, and then just something on how we deal with the trauma transfers that come into our department. So, enhanced use of ultrasound. As we have liked to say, we believe that anybody who's over the age of 50 who presents with abdominal pain, back pain, flank or groin pain, who's been hypotensive, dizzy, or has syncopized, or has a status post-arrest, could be a AAA to proven otherwise. And so the question is, how do we identify the AAAs in that patient population, understanding there could be any other number of reasons why they have abdominal pain? Well, the answer is we use our ultrasound machine. And the bottom line is this piece of equipment which we use has been absolutely essential to helping us move forward to identifying people with AAAs. We think about using the ultrasound machine similar to using an EKG on somebody with chest pain, and it should be analogous to that. The advantages of using an ultrasound machine are obvious. First of all, you can do it at the bedside. You don't need to give the patient contrast. You can take care of unstable patients without moving them. You can get the results within 1 or 2 minutes. And quite frankly, if I can be trained to get some quick images on this machine, then really just about anybody can. So it's a tool that I believe that any busy emergency department should have available to treat and take care of patients in the department. So I'm not going to bore you with too much anatomy, but I want to share with you for about 5 minutes some overview on how we approach patients with the machine, just to demonstrate to you that this is really something that anybody can do. And if your hospital currently is not having use of an ultrasound machine in the ED, let me show you how that would be relatively easy to do. Here's a basic look at the anatomy. Obviously on the patient's left is the aorta, on the patient's right is the inferior vena cava, and the landmark central area of that is the spine that they override. Looking at things in a cross-sectional view, you have some important landmarks here. On the top is the anterior abdomen. On the bottom is the posterior abdomen. The left would represent the patient's right, and the right would represent the patient's left. Now, one of the hallmark things is the spine. The spine appears as a white concave area with a shadow underneath it, and that's what we use as one of our key landmarks. Then, to the left of that would be the inferior vena cava, and to the right is the aorta. And it's important to get your orientation on that. And that makes a little bit of an unhappy face, although we're happy when we find it. We're happy when we find it, but that's basically what it should look like on the screen. And actually, that's another view of it there. Now, what's important is when we're going to do the scanning for the aneurysm, you need to find a proximal, meaning a first, a middle, and a distal area to establish your landmark. So if you have those 3 areas, you know you scan the entire aorta, and you can identify if there's an aneurysm in between. So you need basically some points to mark off of. So we use the celiac trunk for the proximal, the superior mesenteric artery for the middle, and we use the bifurcation of the iliacs for our distal. So with those three things, we basically can identify our three areas. So with the proximal, again, celiac trunk, and that is a cross-sectional view of that. So there's your aorta, there's your inferior vena cava, and anterior to that is your celiac trunk. And then obviously branching off of that, you have the hepatic and the splenic artery. But more importantly, what does it look like on the ultrasound machine? Well, it's basically the same view. So once again, there's your spine, inferior vena cava, aorta, and then you have your liver over there, and bypass it. But then you can see you have the celiac artery, you have the hepatic and the splenic artery as well. So that's the first place where you're looking. Once you find the proximal area, you start moving down to the middle aorta, where you're looking for the superior mesenteric artery, where once again our landmarks are the aorta, the inferior vena cava, and there's the SMA a little bit anterior to that. That's how it looks anatomically. I'll just move through it again so you can see. And my whole point here is calling out that really once you can identify some simple landmarks and what to look for, then you can very comfortably scan the aorta in a couple minutes and know that you've run the list. And if you see something that looks like an aneurysm, you can confidently say that you've looked at the whole aorta. And then lastly, down to the distal. So for the bifurcation, once you hit there, you recognize that you've run the entire aorta for measurements. Aorta, IVC, and here's another look at it here. What's nice on this is if you look at it in a video loop, what you can actually see is as you scan down, you can see the aorta bifurcate. And if you see that, then you recognize that you've done the entire distance. So that's really it. And with the help of Dr. Cadigan, who again is one of our board-certified emergency physicians who's fellowship trained in ultrasound, she actually was able to take our entire staff of emergency physicians and run us through a course where we basically now can use that machine, and at the bedside, if we have any patient who presents with chest pain or abdominal pain, who's hypotensive or syncopized, we can roll that machine in while we're talking to them, taking history, and do a quick scan. And I can tell you anecdotally, we've had one experience where a patient came in who was a car accident. It turns out the reason they syncopized is not because they hit their head when they hit a tree, but they had an aneurysm, and that's why they syncopized. And as part of our identifying scan, we were able to pick up that the aneurysm was the cause, something that we wouldn't have done necessarily a couple years ago. They would have had to go to CAT scan and have additional testing to get that. This is the sagittal view. I'll just simply point out you can look at things a couple different ways. The anatomy is the same, and the important thing here is just to simply recognize that you need to understand where the branches come off so you can distinguish between the aorta and the inferior vena cava. And that'll just help you so that you can, if the patient is hypovolemic and the inferior vena cava is collapsed, you can still identify that versus the aorta. But what's really important here is to take a look at some pictures of what the AAA looks like. It takes just a little bit of time to adjust your eyes to recognize that that is something which is different than what you would normally see. If you see enough normal aortas, then you can begin to identify that this is one which is larger than normal, greater than 3 centimeters perhaps, and if greater than 5, obviously significantly at risk for some type of injury to that, and or if there's any thrombus in there. And obviously we scan them both in a transverse and or in a sagittal view. Here's a couple more aneurysms, and you can see some various degrees of thrombus inside there. In the upper left-hand corner, you can see one where it's primarily making a little bit of meniscus on the bottom. You can see the one on the bottom right-hand corner is essentially filling it up in a concentric circle through the entire aneurysm. There are some pitfalls, though, that you have to watch out for. One is that the confirmation of rupture is difficult to do with ultrasound. It's not something that you often see. It's really more of a diagnosis that you would make clinically with ultrasound. But when you see it, you can obviously see a breach in the wall, and you might see some blood in the retroperitoneum. This is absolutely probably one of the most important things to know, though, which is how you measure it. People, if they're not careful, will measure the diameter of the aorta, measuring from the inside wall. What this person has measured here is actually from the thrombus, when in reality what you really want to measure is that distance there. So again, it takes time and practice, but in our department, what we've done is we put us through the paces. We do 25 ultrasounds with Dr. Cadigan. She then clears us, credentials us, privileges us to do that, and then we're on our own. And then I have to tell you, it's rather exciting when at an attending meeting someone mentions that they had a case where they used the ultrasound machine and they identified an aneurysm that before they might not have, or they may have had to send the patient to CAT scan to get. And so identifying it earlier, getting the vascular surgeons involved earlier, perhaps reducing any need for additional testing is pretty exciting. We also have to be careful that on the sagittal view, you're identifying what's the aorta versus the inferior vena cava. And the key there is looking for your branches. So if you look at the slide on the right, you can see your celiac and splenic coming off, which makes you recognize you're dealing with the aorta on the sagittal view. Let me talk briefly about vascular extremity trauma. Actually, before I do that, again, I think the key points on that is really this. This machine, whatever machine you may choose to use, should be considered another tool for an emergency physician in an emergency department. The more facile you get with it, the more comfortable you get with it, the more you roll it into part of your normal evaluation of the patient, I think the more likely you are to identify aneurysms. And so that certainly has been our experience. Vascular extremity trauma, we obviously live in a modern, industrialized world with many high-energy forces, and obviously extremity injuries are quite common, and so we have to be looking out for those. 40 to 80%, depending on what you read, of these patients, the musculoskeletal injuries are a result of blunt trauma. Now, blunt trauma in this case rarely causes an immediate threat to life and limb, and therefore they must be properly managed to prevent any threat to life and limb. Our goals in the emergency department are to recognize the presence of the injuries, it's to protect the patient from further injuries, and is to prevent any complications as a result of it. Now, obviously, when the patient comes in the emergency department, one thing we want to do is we want not to be too focused on one thing and miss the bigger picture. So, for example, if you have somebody who has significant force to the body and they have a long bone fracture, which is recognized to be above or below the diaphragm, you have to immediately be concerned about other injuries, including internal torso injuries. If they have an open femur fracture, obviously they're at risk for significant bleeding. Crush injuries are at risk for rhabdomyolysis and acute renal failure. And obviously, if they have some intact myofascial space, then you'd be worried about compartment syndrome. I could list another half dozen of those, but the important point there is that obviously you don't want to become singularly focused on the one injury. You want to keep an eye on the big picture. Pitfalls. Do not get distracted, and that's why they teach us to do the ABCs, and in this case, D and E in the emergency department, D being disability and E being exposed to patients. So the most important thing is to get them undressed so you can look for and identify other injuries. What's very important on the primary survey when you're taking care of patients with vascular injuries is obviously hemorrhage control. People who have femur fractures, for example, may have as many as 4 units of blood loss within a short period of time, putting them into class 3 or 4 shock. And so obviously these are the types of patients who need to be typed and crossed immediately, and if possible, be transfused with O-negative blood. We often see people come into the emergency department who have spurting vascular injuries. As an emergency attending, I have to tell you this is one of the most fun things that you can take care of, because if you walk in the room, there's often people who are scrambling around, and certainly the more novice people. Obviously our experienced nurses know what to do, but if you have an intern who hasn't taken care of this before, they're not sure what they do, they're grabbing a big gauze pad and they're pushing it on there, and then you simply walk up with your blood pressure cuff, you pop it up a little bit, and then you put your little finger on that bleeding pseudoaneurysm or something like the little Dutch boy, and you hold it, and then you call Clem or Manny or Sean or any of these guys, and you say, I have someone down here that you need to come see. So the key here, it's just very strict, direct pressure on that area. Obviously big bulky dressings just become big bloody dressings in a short period of time. And obviously immobilizing the fracture is very important to prevent any further blood loss and control the pain. It's important for us, if anybody here is pre-hospital, to know the mechanism of injury. So if you come in, the position of the patient in the car, whether or not there was a seatbelt or airbag, if they fell from how far, or whether it was an explosion, are things that will help us manage not only the vascular injury, but the other things that are going on with the patient. So we picked that up on secondary survey. And we want to know the environment the patient came in. Obviously, if it's extremely hot or extremely cold, that plays into some of our decision making on the patient. We also want to know from the pre-hospital provider, basically, what position the patient was found in. If someone comes in who's been laying on the ground for a long period of time, we're worried about, obviously, rhabdomyolysis or other problems such as that. If there's obvious deformities or dislocations that they've bandaged up, they should probably tell us about that, because that may not be something we get to the first 15 or 20 minutes while we're intubating them or putting in a chest tube. So they have to provide that for us so that when we move down our pathway, we do not fail to take care of what might be an acute vascular crisis with an ischemic limb. The patient has to be fully undressed to fully appreciate the degree of injuries that they have. Obviously, our goal is to identify life-threatening emergencies on the primary survey, identify life-threatening injuries again on the secondary survey, and then a systemic review to avoid anything else. So what is the cause of high energy traumas? In the civilian world, primarily it's motorcycle accidents. That wouldn't surprise anybody here. Obviously, motor vehicle crashes. Between the two of them, you make up approximately 50%. And you can see what makes up the difference there. We do obviously see gunshot wounds, and our vascular surgeons are often involved in the care of those patients. They are often damaged from several different means. It's not only the immediate gunshot wound itself, but the secondary trauma as a result of that. Fortunately or unfortunately, again, with the recent wars in Iraq and Afghanistan, we've learned even more than we knew about gunshot wound injuries and the type of injury pattern that you can get as a result of them. The most important thing is that if you have a high velocity change, you provide a shockwave effect, which causes this cone of cavitation. And it's that type of destructive energy, if you would, that often leads to vascular types of injuries. So they have to assess the soft tissue, and they have to do a vascular assessment. And what's really important here is that there are certain types of fractures that make themselves at risk for vascular injuries. So we need to pay very close attention to supracondylar fractures. We need to pay very close attention to posterior knee dislocations, distal femur fractures, and proximal tibia fractures, because obviously each of them is associated strongly with a vascular injury. So a good assessment of their neurovascular state is of paramount importance. We look for hard and soft signs of vascular injury. A hard sign would be evidence of pulsatile bleeding, a palpable thrill, an audible bruit, a sign of distal ischemia, or a visible expanding hematoma. These would be clear signs that this is a vascular injury, and this would necessitate us talking to our vascular surgeons immediately. On the other hand, there are also soft signs, which we need to pay very close attention to, which may convert to a hard sign. So is there a hematoma that's not pulsatile? Is there a history brought in by the pre-hospital provider that they think they saw an arterial hemorrhage? Is there a slight sluggish capillary refill? Is there any paresthesia or any temperature gradient? So these are things that, again, we need to pay very close attention to. If they have a hard sign, obviously the goal would be arteriography or take them straight to the OR. And if they're soft signs, then obviously we would look to do an ABI, a measurement of the blood pressure in both the upper and the lower extremity, get the ratio, and then you can see there, depending on what that ratio is, you would either observe the patient and or you could consider taking them to arteriography or the OR. I will say very quickly that we like to describe our injuries, and we use the term no lard, okay? Now, so what we're looking for is the neurovascular status. Is it open or closed? The location? Is it angled? Is there rotation and displacement? And I think it's very important that we have consistent language with how we describe our injuries to our colleagues so they get a visual understanding of what we're seeing in terms that make sense to them. This basically goes through, and I won't go through all of them, that certain types of joint dislocations obviously can lead to certain types of appearance, and therefore we need to pay close attention to that. And of course, no one can get out of the emergency department without life-saving tetanus, right? So, I knew someone would laugh at that. So, and these are the types of injuries that require tetanus. And then obviously early initiation of antibiotics, and gunshot wounds are primarily at risk. Certain patient populations are more at risk, so if you happen to be unfortunate to be diabetic and get shot, then you absolutely should not only get your tetanus, but you should probably get some antibiotics before you leave the ED. And then I put this in really because I thought it was interesting. I quite frankly have never used it, and I'd be curious if any of our colleagues have, but there is actually a way to objectify, if you would, the degree of injury that one has to their extremity, and perhaps we may hear about this in the other lecture, I don't know, but it's called the Mangled Extremity Severity Score. And basically, as you can imagine, that spells mess. And so what you do is you take each of those points and you add it up, and it basically gives you an objective measurement of the degree of injury that the person has using the degree of skeletal injury, the degree of ischemia, whether or not they're hypotensive, and their age is sort of the defining categories. All right, lastly, and I only have about 2 or 3 slides today, I want to talk very briefly about some of the challenges an academic emergency department has when it comes to the transfer of patients. Now, I mentioned we receive about 700 med flights a year. I'll tell you that our emergency department receives upwards of almost 5,000 transfers every year to our emergency department, and that number grows every year. Just recently over the holiday weekend in one day, I think we received something like 30 transfers in one day. So it's important how those patients are managed pre-transfer, inter-transfer, and when they arrive. And what I'm going to present to you primarily is a list of concerns. I think this would be an interesting topic all to itself about how you manage these patients. But in general, In that subset, actually I said 5,000, I guess it's closer to 4,000, there was 270 vascular transfers. Now let me tell you, the number of patients who come in who have vascular injuries is probably twice that high. So they may be requesting something for trauma, or they may be requesting emergency. But when they say, I want a vascular surgeon, that number alone is 270. So let's call it 400 or 500 transfers a year that come in who need our vascular surgeons. 90% of those patients get admitted. So this is a sick or injured patient population. And these are the things that I would like people who work at other hospitals consider when they're transferring patients either to our hospital or to another one. What is the diagnosis before they send them? What treatment needs to be rendered before that patient leaves? Is it more appropriate to treat them at the outside hospital first, or does the risk-benefit ratio err on the side of sending the person right away? What if there's a change in condition en route? What's the best way to send them? Is it better to send them by medevac, where they'll be here in 30 minutes in the air, versus ground, where it may take an hour and a half? The latter may be appropriate sometimes, but not always. Are there any other comorbid conditions? Making sure the paperwork is filled out is important, but more important, if they have imaging done at the outside hospital, sending that so our vascular surgeons can immediately look at it and make decisions, rather than exposing the patient to more radiation or a second dose of contrast. Obviously, we will alert the vascular surgeons about these patients so that they can be available either when the patient arrives or soon after. And obviously, in some cases, they need a preoperative clearance. So in summary, what I'd say to you again is thank you for the opportunity to speak to you. This has been my pleasure. I'm looking forward to the other talks as well. When dealing with vascular emergencies, it's important to have the best and proper tools. In this case, I would make the case that having an ultrasound machine available to look for aneurysms is probably something that every emergency department should have these days. It's important to have the proper teams, and we are very fortunate to have the best with the vascular group and all of the providers in their group available to us to get not only their presence, but the studies that they can perform for our patients 24/7. And it's best to have one-on-one communication, so that if you do call our transfer center and you need to speak to somebody in the emergency department or one of our vascular surgeons, having that dialogue ahead of time to decide what the best way to handle that patient is probably going to be the best thing for that patient. Thank you very much.